Yeah, welcome everybody. Hope everybody's off to a good week and you're doing all right with the heat wave. It's been a little bit hot here in San Antonio, but we got a nice little shower this afternoon, Guy, and it cooled things off a little bit. It's kind of nice.
Yeah, we've had so much rain that they're spraying for mosquitoes. So we usually don't have that big of a mosquito problem out here on Anna Island, but it kind of makes you nervous when you're on your porch and you get once you get a bunch of that stuff on you. I ran in the house the other day thinking I'm going to probably get killed as well from the spray, but all is well here. We're looking forward to a 4th of July. We even have a little 4th of July special we'll talk about here in a second, so in 2 minutes. How are things? Where are you physically located tonight, Doug? You're out in the West Coast.
Yeah, San Francisco, California. Nice and warm. Been pretty much perfect weather. It's in California. I hate to brag. Everyone's always like, "How's the weather?" And I'm like, "Oh, it's pretty much perfect over here." But no, it's we've had a rainy season as well, and so it's just nice to get the sun out again and getting out and about. Really feels like summer now.
Very good.
I'm not sure what that means, Doug, for somebody in San Francisco. I've been to San Francisco in the summer, and who was it said the coldest, winter I ever spent summer in San Francisco?
Yeah, Mark Twain. Yep.
Mark Twain.
Yeah, it can turn on you really quick. It'll be a nice day, and then all of a sudden the sun sets, and then the wind picks up, and before you know it, it's just really chilly. And that's why you'll see down in like the boardwalk areas or the marina, there's all these sweaters and people selling sweaters, and you're like, how in the world are people selling all these sweaters? And then as soon as the sun sets, you'll see everyone pick up and start buying sweaters. It's kind of funny.
Well, it looks by my clock 8 o'clock here in Florida. Right. So I think we're going to get started. Welcome everybody to CBC Implants and Dental Sleep Medicine. I'm Dr. Guy Yatros. As I mentioned a minute ago, for those who are on, I have Dr. Richard Drake with me, my partner, lots of you are familiar with, and we're really, really, really honored to have Dr. Douglas Chenin with us. He's just a real expert in this field, and I think Rich and I are going to learn a lot as we go through this tonight. I'm going to take care of a little bit of housekeeping, and then we're going to let Doug just kind of take this thing over for the most part. We have 2 more webinars already on the books. We'll be adding more, but the next one's July 11th, Dental Sleep Medicine. This is great for your team. You can have your team on as well, or bring the message back to the team. Rich, you have a pretty big team in your office now. I hope we're going to get some real good pointers out of you of all that. How many devices did you do last month?
We did 79 in the month of May. So yeah, that was a good busy month, and it takes a fair bit of staff to do that. And as most dentists know, that's one of our biggest challenges is staff. So I think we'll have some real good pearls on that next one.
And then in August 15th, we'll be talking about dental sleep medicine billing. And, this is going to go into a little bit more detail about out-of-network billing in particular, instead of just having an overview of billing like we often do. So put those down on your calendars, and we hope to see you there. Dental Sleep Solutions and DS3 puts on courses all over the country. So we do a lot of traveling. I'm confident we teach the best course out there on how to really implement this in your practice. So here's some of the dates. We'll put this up at the end as well. But if you want to come to a 2-day course, we have some 2-day courses where you have your hands on. You get to actually get a device and a lot more hands-on. We are offering $200 off on those tonight. And if you want to come to the 1-day course, we typically only offer $50 off, but Rich and I were talking earlier, it's 4th of July, we're going to offer $100. I don't think we've ever done that before, because the courses are already very reasonable for the courses. If you type in tonight course, and if you know which city you want to go to, type those in. So we'll put that up again. And time's running out to get the discount on our symposium that we did last year. We're doing it again this year, but last year was fantastic is what I want to mention. Doug, are you going to be with us on this, I think, this year?
Yeah, I believe so. I got the invite, and I appreciate that as well. And I did do a tentative confirmation, so I should be there as well.
Well, fantastic. It was really a fantastic course last year, all very, very practical. How you do this in your practice, just 1 hour, quick, really things that you need to know. And I personally have been doing this, and Rich, you've been doing it about the same length of time, 17 years each. And I learned a ton, didn't you, Rich? Just even from the speakers there.
Yeah, you always learn something, and we are making a real effort to make that practical implementation types of things. So I think you'll get something out of it, regardless of whether you're just getting started or you've been doing this a while. So that's our mission statement. You know, we're the most trusted, innovative, customer-focused provider of solutions in dental sleep medicine, period. So if you don't know who we are, what we do, you know, look us up and do that. This is just part of what we do all the time, are these types of educational opportunities. So
I want to mention on that, that's not only all we do, that's all our whole team does. We have a whole team of dental sleep experts that go to work every day, and their whole mission is to help dentists succeed at dental sleep. So if you're interested in knowing more about that, or even if you just have a challenge in dental sleep, some questions that you'd like answers for, then just type in tonight consultation, or just consult for short, and we'll contact you, answer your questions, tell you how we can help you in the future. And it's worth your time just to be able to talk to one of our experts. So just type into the question box. By the way, there's some things going through the chat box. You can type that in either one. But as you get questions tonight, everyone's muted because we have about 300 people registered tonight. So we just can't leave the mics on for everyone. But if you have a question that you absolutely have to ask verbally, hang on to it, raise your hand at the end, and we'll get to that. In between, type the questions into the question box, and we'll answer them as we go, and we'll make sure we get to all of them before it's over with. DS3 is, again, what we help you do from end to end, everything that you need to make a dental sleep practice successful, because that's what we've been doing, and that's what we basically specialize in. So that's me on the left as you're looking at your screen, and Rich and I have been doing this for 17 years. Rich, that's anything more to add on us?
now I have a little bit more hair than that, and Guy actually has a little bit less hair than those pictures. But otherwise, that's good.
Yeah, and by the way, we have our webcams on. Dr. Chenin does not, so if you're fiddling around trying to get his on, it's not. So you're forced to look at. He's much better looking than either one of us. So it's a shame that it turned out this way. But you can you can look at the two of us while he talks. And honestly, I'm gonna just we're gonna hand it over. I think Rich and I will have some questions, but this is gonna be a little more learning for us, because we are dental sleep experts. I don't think there's two people in the country that know much more about dental sleep than Rich and I do. And we know a fair amount about CBCT, but we certainly are nowhere in the even realm of knowledge and experiences as Dr. Chenin is. So we'll hand it over, and I'll quit touching the mouse there, so you can even move the mouse and the slides there. Okay, very good.
Perfect. Well, thanks again, guys, and real pleasure and honor to be here. And thank you for all the attendees who are logged in and ready to learn more about this. So we're going to jump right into cone beam and dental sleep medicine. And just a quick intro into my path into cone beam and how I got involved. I started to consult with this company, Anatomical, back in 2006. This is when cone beam was really starting to pick up. It had already been on the market for a while, but this was really still beginning early on. After consulting with them for a number of months, I got offered to be their full-time clinical director, and I was only in a private practice doing general dentistry at the time, and figured a good pathway to go down, and really glad I did, because I had a lot of fun and really got to get my hands on the technology and really help with the development, and just a really interesting and fun time. And so my job at Anatomical was very varied, and I worked on all these different projects, worked on developing the in vivo software, or the treatment studio software. It's called both different names. I worked on Airway applications, ortho applications, TNJ implants, surgical guides. And so really worked on a lot, and stayed with them for over 5 years. And I still consult with them. I'm no longer directly on the team, but did a lot of work with Anatomical. And then shortly after that, actually right after that, I transitioned into working with beam readers. And beam readers, they are a radiology company that does the radiology reports for the cone beam scans. And for a while, we were doing this implant service. We no longer do it. The labs basically took that over, and they do a really good job at doing this kind of implant planning service. But for a while, we were doing this. And this was fun for me because at Anatomage, I got to help develop the technology and teach it. And then this was my first big splash into really implementing it. And so over a course of several years, I worked with about 1,000 different doctors and trained them on surgical guides and helped them with many of their cases. And so that was a lot of fun. Got to see a lot of different things doing that, and really, was able to take the technology to the next step. Around that same time, I also formed my own company, which is clinicallycorrect.com. It's an education company. I teach cone beam technology, whether you need help for implants or ortho or dental sleep medicine. I have a few DVD products, and I do on-site training and lectures and whatnot. So if you ever needed some cone beam help, look me up, clinicallycorrect.com. I've been doing that for a number of years. And then I also have my practice, which is a dental sleep medicine only focused practice, where we utilize the cone beam technology in our office. We have the ICAP machine, and we use it for path screening, looking at the airway, TMJ assessment, sinus assessment. I can give you a sampling of all those things that we can do with it and why it's so valuable. I'm not going to say that you have to have it to practice dental sleep medicine, but if you do have it, it can benefit you, and that's what I want to point out, is how beneficial it can be and the different things that we can do. So moving right along, we'll look at just some foundations of cone beam technology, and this is really basic, but I just want to make sure everybody's kind of on the same page and kind of has just a groundwork. So really, this technology has been out for a long time. We're going on 20 years, which it doesn't seem like that because it really hit the market really hard in kind of the mid-2000s, late 2000s. But it's been out since 1996. In America, we got our first one in 2001 at Loma Linda, and that was the old Newtome machine where you were laying down. Huge machine, $500,000. They didn't sell too many of them, but a few people bought them here. And that really started it. The Newtome has gone through different iterations, and there's new machines out, but that big laying down machine was the very first one. 2004 was a big turning point in the history. The ICAT came out. It was a less expensive machine, an upright machine. You didn't have to, the patient could sit down in it. They didn't have to lay down. Really small footprint, so it can fit in dental offices. And this really turned the corner of people really adopting it, private practices, academic institutions. That really pushed it forward with that machine. And then after that, there's been a whole host of new machines. Cable Kerr has a handful, and a whole bunch of other companies came out and have joined this cone beam march. And over these 20 years, basically we've seen tons of machines come out. Tens of thousands of machines have been installed just in the U.S. alone. All the schools have them. There's research on countless topics. You can look up pretty much any research topic in CBCT and find something pretty neat out there. And there's a ton of different softwares, services, machines, different things you can do. So it really has blossomed, and a ton is available. The trends that we've seen, the machine has gone down in cost a lot. There's different hybrid options. You can get 2D and 3D, get like your Pano or SF with your cone beam. Faster scans, less radiation, even though there was already a very small amount to start with. So those are some of the trends we saw, and now it's pretty commonplace. Most people know what cone beam CT is, or CBCT, or 3D imaging. They got an idea. But back in just 2004, 2005, or 2006, when I started Anatomage, it was pretty much unknown. And so what we'll do now is just take a look at some of these terms that are thrown around. The voxel, just to jump right in, the voxel, you've probably heard this. It is the measurement of resolution, and it's similar to a millimeter. So if you hear someone say a 0.2 voxel, just think 0.2 millimeters. And that's what's so neat about this technology, is we can get that 3D pixel and such a fine pixel too, 0.2 millimeters or 0.3 or 0.4. such a high degree of resolution and really see very clear things. The Hounsfield unit, this is the radio density unit measurement. So sometimes you'll see people mention that. However, most of the time people are talking about voxels. If we're talking about scan quality or detail, they're usually talking about voxels, how high the resolution was. There's different types of resolution, contrast resolution, and these are just the ability to distinguish different grayscale shades. And I have a quick little graph here, but just to point out some of these machines with 16-bit detectors, they're grabbing 65,000 shades of gray. It's staggering the amount of data, and that's in one of the pixels, one of those voxels. There's that many shades of gray just in that one little voxel, and you have a whole image filled with them, and then you have several hundred images that compile together to make the cone beam. So all in all, it's just a massive amount of data that gets compiled together and put into this one cone beam image or cone beam data set that we can really look at from all these different angles and tools. So this multiplanar view, this is pretty important. This is the standard view within medicine and dentistry now to look at a cone beam. Obviously, there's all these unique modes of looking at it, but the axial, where we're cutting the patient basically in half, sagittal, which separates left and right, and coronal, separates anterior and posterior, and then the volume. Sometimes there's a fourth thing in this fourth window. But these three modes, the multiplanar mode, is how we generally look at CT scans and how we kind of correlate images together. So if you're looking at one structure on one of these images, you can put those crosshairs together and see that same structure in all the other ones. So you'll hear me throw out the term axial and sagittal a lot. That's why I like to show those up front. And then volume rendering is just a 3D compilation of all that data together. For the most part, I think everybody on this call understands the benefits and limitations of 2D and the benefits of 3D, but I like to just state them. So in 2D, we know that there's distortion. There can be magnification, especially if the patient's tilted down or up on a panel like that, for example, or a bite wing that's tilted. We get these ghost images, superimpositions. The big thing here, we don't get that facial lingual view of the arch, very important for implant cases. And similarly, we don't get that medial lateral view of the TMJ in the 2D. So we're missing a dimension. And this image is pretty static. You can't manufacture off of it. So once you take it, you're done. And that's really the opposite of what we can do with cone beam. We can do so much more with it. A big point to make here, though, is 2D imaging for caries detection is still the standard. So the bite wing definitely has a place. So again, I'm not saying throw out all your old equipment, but let's look at what cone beam can do in addition to what we're using already. So the benefits of 3D, again, just kind of augmenting the limitations of the 2D is we don't get distortion. There's no magnification, and the image size to real size is 1:1. And people have probably heard that 1:1 ratio. That's what they're talking about, the image size to real size. So if you dissected a patient or a cadaver and took the same scan, you would see that same anatomy in the scan. The ratio would be the same. So whether or not we zoom in digitally, the ratio of it's all going to stay the same, so the measurements will be the same. Other benefits that we have are we can get that volume. We can get any cross-section, again, whether it's a TMJ cross-section, a dental arch cross-section, whatever it happens to be. We could do unlimited number of reconstructions. And essentially, that's a virtual patient. We have this virtual patient that we can look at from any angle, very powerful tool. And we can connect it to manufacturing. So we can do those surgical guides, we can get models, we can do so much with the data and integrate it with optical scans even, and go from there. And so really, cone beam is becoming the matrix of digital patient information. And I think as time goes on, we'll see some exciting things, perhaps, jaw tracking, being combined with cone beam, occlusion, and articulation, and all sorts of stuff. We'll see more, and cone beam will become, or it already is, but it will further become the matrix by which all this data is kind of put together. I like to talk about dose a little bit, just to touch upon it so that it's accounted for, and then to go forward from there pretty quickly. what I like to do is just give you a quick comparison of kind of how an effective dose is, how much all the different tissues absorb the radiation, weighted. So it's different. Effective doses is a pretty good calculation. They do it different for children and adults. And what we find is that this is probably the best thing to know, is that a medical head CT, just a head and neck CT in medicine, is about 10,000 microsieverts. If you compare that to an average cone beam, a large one, it's about 200 microsieverts. So we're literally off by magnitude. So right off the bat, that's the biggest thing I always like to show people, is that medical CT is a totally different animal, totally different magnitude of radiation, really. And with cone beam, we can get it down really low. Comparing that to our standard images, so an FMX, it could be anywhere from 35 to 170, Pano is 15 to 30. And so for some people, especially in the orthodontic population, if you get one of these fast scanners, if you use one of the lower radiation settings and you get a dose of around 200 or 100, even lower, because it's possible to do that, you're basically getting more information less dose than you would if you added a few of these up. So if you took a Pano SF and an FMX, you could be hovering around 200, where that's what you would be for a full cone beam. And so there's different ways to look at the dose information, but again, I think the big summary is it's a magnitude different from medical CT, and it's within the realm of the dental X-ray. And I think that's a really important point, is that when I tell patients, hey, we're going to do an X-ray, I just say it's a dental X-ray. It's a 3D dental X-ray. I call it a 3D Pano a lot because they've heard Pano, but I don't really stress the CT. Yes, question?
So I have a CBCT, and this was one of the big holdups for me. My partner wanted one. She had one in her previous practice, and I was so off base. I thought they were 10,000. I didn't know the difference between the CBCT and the CT. I think it's a pretty big. A lot of people, maybe I'm the only one that felt that way, but it was bothering. And so I selected one. The one I ended up getting was the Cable Kerr one that it has a pre-scan first, and it was told to me, and from the research I read, that minimizes exposure even more because it automatically adjusts the dose based on big guy like me versus small somebody. Do you believe that helps if that has that?
Yeah, they've all come up with really clever ways, and that's one of the clever ways to do it, is like a weighted type of a pulse, and then another one is just a straight pulse. Well, rather than turning the dose on, it kind of pulses, so it doesn't hit continuous radiation as the rotation arm is going around. But yeah, that's one good way of doing it. So children will receive less. That's the idea. Or a smaller person. And so, yeah, I think that's a good technology.
Yeah, I think when I realized this too, I fly about every other weekend giving a lecture, and one of the information I saw, 8 hours is, what is it? Yeah, 3 to 9 an hour. I fly 8. I'm getting, half of one of these doses each way or something every other weekend. So put it in.
Yep.
So that'll excuse anything that's going wrong, my brain or something.
I know, right? The air travel adds up, and it'd be up to 9 an hour, and that's about as much as you get in a regular day. And that's the other thing too, just to mention that we get radiation just sitting here. I mean, we're all being exposed right now. So the big. Oh, go ahead. I'm sorry.
No, thank you. That was good clarification. Thank you.
Yeah. So the big thing, the exposure is consistent with other dental radiographs. I think that's what I want to leave people with, and it's a magnitude less than medical. So cone beam, it's in the realm of dentistry, the magnitude less than medical, and it's justified based on the risk. If we're placing an implant next to someone's nerve, we want to know that. If we're treating someone for sleep apnea and they have a history of chronic nasal congestion and we have no idea what's going on, we want to see that. And so by doing a cone beam, it is justified because the treatments and illnesses that we're working with are that severe that all this information can really help us, and just a little bit of help for a severe case can really make or break it. If you're interested in more stuff about dosimetry, I encourage you to look at Dr. Sean Carlson. He has a little podcast. There's like 3 or 4 that he recorded, and he just has a really good job of where he just breaks down the dosimetry, and he talks about risk as well, and how it compares to other things that we do in life, how they've put x-rays on that scale of risk. So he's probably the best person to look up for dose, or if you want a video. What we're going to do now is jump right into its role in dental sleep medicine. That whole intro was just kind of a quick, some tech terminology that you'll hear me talk about, a quick talk about the dose again, because I think that's important, and a little bit of those history trends. And now we'll jump right into looking at what we can do with this in the dental sleep medicine arena. And I guess this is a pretty good summary statement, is that patients with sleep apnea usually have coexisting issues or related issues in these exact structures that we can see with the cone beam. They usually have these issues with their nasal passageways, sinuses, joints, vertebrae, just their dental relationship, function, and occlusion. And so all of those, this big area that they have these conglomerate of signs and symptoms that we can see, we're able to scan it. And I think that's so beneficial. And so kind of working from that premise that every other patient could have something coexisting, that's kind of how I'm operating. I'm like, what else can I find? And that's what kind of cone beam helps me do. Even though in a really good clinical exam, you'll pick up a lot of things, the cone beam can really help out as well. Another big point is that sleep apnea has a pathophysiology rooted in anatomy. So the more we know about anatomy, I think the more we know about how they're functioning. And then it provides this comprehensive modality that is just, it really is a snapshot. It's that virtual patient again. So in terms of having the records, it's such a good record tool as well, just to have, again, that summary of the virtual patient. What can we do with it? There is some assessments and some diagnostics. The assessments are more on the anatomy, and the diagnostics are more on the anatomy, and the assessments, we can make assessments and predictions about function, but we can't yet diagnose that way, and I'll talk about that more. I just mentioned that it's a good record, especially for joints. I like just having a really clear picture of the joints, and that's how they came in. And again, we can use it for screening. And in the title, there was the implants, and really the implant part is all right here. Is anytime if anybody's on the call who has came here for that implant part of the title, the big thing I wanted to mention was, just because it's an implant case doesn't mean they don't have sleep apnea. And so many times when I was at beam readers, we would have that implant case that would come through, and we'd see the airway, and then we would immediately kind of turn the conversation into, all right, let's look at this. And we found a few. And so really, as a screening tool, if you're doing anything else with your cone beam, look at the airway, because they might have said, no, I don't snore, I don't, they kind of fell through the cracks on the normal screening. But then all of a sudden you see the anatomy, you start probing deeper, and you find another patient.
Yeah, Doug, on that note, I will add, I think it's really beneficial for not only for the screening, but it helps the dentist have something tangibly to talk about. It's almost like an intraoral camera, shows a broken down tooth, and now we can talk about it. I know you've got some pictures coming up, but I want to put that thought out there. It not only helps the screen, and I really think it helps educate the patient and get them to start thinking about, oh, maybe I do have an airway problem.
Exactly.
Yeah, very much in a lot of practices.
Yeah, no, good point. Really good point. And you can really just show them. And then someone made a little note in the chat, if you take a scan for an implant, are you evaluating the airway? And it's, if you scan for an implant, you get all that data, so you can evaluate the airway, and I think you should. And really, if we take an image, we should be looking at everything in the image. So the limit is right here. It is not diagnostic for any sleep-related breathing disorder. Cone beam imaging is a wonderful imaging capturing system, but it is not a functional testing unit like we do with polysomnography. So just to be very clear, polysomnography is the standard. It's not the gold standard because there's no silver standard. It is the only standard for diagnosing sleep apnea that we use, and cone beam helps with that. It helps to paint a picture. So functionally, we can guess what's happening functionally from the cone beam, and there is some research, and we'll talk about that, but we use polysomnography, of course, for our diagnostics. That being said, cone beam does give us really the best kind of case scenario? And that's another question that always comes up. Well, hey, you know, the patient's upright, they're awake, they're not snoring, you know, they're sitting there, you know, level-headed. So what it is, it really is the best, it's the best case scenario. It's, hey, you know, Miss Jones, this is your airway while you're awake, sitting up, and there's a problem right here. So when you go to sleep, you know, I'm sure there's a problem. Are you snoring? You know, then you go down that pathway of digging into it further. And so I think this is really neat. I actually like the fact that it doesn't take that perfect picture of what their airway looks like when they're, you know, asleep, because one, we couldn't do that. We couldn't have our patients come in and scan unless they're asleep. But two, it really is just the best case scenario. And patients get that. It's like, hey, look how bad you are right now while you're awake. Imagine when you lay on your back and sleep and everything relaxes. And so that limitation, I think, is overcome. You know, again, sleep apnea is rooted in this craniofacial anatomy. We're going to be looking for small, retrognathic, micrognathic, maxillomandible, inadequate arch form, that steep palatal bolt. We're going to look for nasal issues, the soft palate, large tongue. Some of these things we can't see in cone beam. Some of them we can. The palatal-glossal arch, palatal-pharyngeal arch, those would be more of an intraoral view. But everything else we can pretty much see with the cone beam. And as soon as I look at the cone beam scan, that's where my eyes go. There's a quick orientation. The basic cone beam image is this sagittal cut right at the patient's midline. And just to compare that to the cartoon, so you can see, you know, we still have the soft palate over here in the uvula. Same thing over here. You can see it in the gray scale. It's just all gray, so it's a little bit confusing. You can see where the tongue is kind of separate within the oral cavity. You can see the soft palate. You can see the bulk of the airway. If there was swollen adenoids, they'd be up here. There's our nasal cavity. So just a quick orientation. This image, that sagittal image, is the one I use a lot, and it's the one I go to when I open up a scan. I like to talk about this airway analysis tool because it is one of the tools I helped develop when I was at Anatomical, and it's become, I think, one of the more commonly used tools, if not the most common airway tool. It has its limitations, but it has some benefits. The total volume isn't real too important right now, but the minimum area is, and I think that's where most people are focusing their attention on what that value actually is. And so within the Anatomical software and other softwares, you can do this type of assessment where you just pick a few points, the airway fills in, and it finds that the bottleneck for you and calculates it. And so what we found is, here's another picture of that. Sorry, just to go forward. Just showing how that multiplanar view where all the patient's images are correlated together, and then we have that airway measurement. And so you can get a really good detailed picture of the airway from all those different views.
You know, Doug, back on that one for just a second, since you've got control, let's let you do it. But I always look too at an oral surgeon that I teach with down to Pank. He pointed this out to me. He calls it the tongue bubble. And if you look at these people that have these narrow airways right up, their tongues obliterating the oral cavity. You don't see any darkness above it. And boy, since I started looking for that, I really see that most of the people that I see that have the problems, that you don't see any darkness above the tongue. The tongue's postured really tightly up against the palate. And then he showed a lot of cases that he's treated with MMA surgery, and he's not telling the patients to move their tongue or anything. And in addition to the airway being the minimal area being a lot larger, now their tongue's postured much more relaxed, and they have what he calls a tongue bubble with a black area.
Yeah.
Do you notice that as well? Is that something that
you know?
I
do look for tongue posture, and the one posture I'm looking for is the really lazy tongue, usually the one that's riding really low. And I think I have an image of that where you see too much black space. But I get you. I think that's a neat point to mention, is that, you know, if you don't see any gaps in airway here, that means the tongue is completely filling up that cavity. And there's nothing showing at all. And then you'll see the other patient who is kind of the opposite. They have this really lazy, low tongue posture, which is usually associated with mouth breathing and nasal congestion and whatnot.
don't want to make you run behind, but what are your instructions for the patient? Do you tell them to relax their tongue, or just bite together and don't tell them? What do you usually tell them? Excellent
point. Yeah, really good question. Really good question. I don't tell them anything about the tongue, because anytime I tell them if I say tongue, all of a sudden they stick it up, they point it, it's curled, the tongue gets funny. So what I just tell them, I say, close your teeth, bite down into your normal or into your deep bite, and close your lips. And then
Perfect.
just stay still, don't swallow. Yeah, so I try not to wake up the tongue. Anytime you you mention the
Totally
tongue's name, it wakes up. And I like how you mentioned that, because even though the focus right now in the slide is this airway area, I like looking at everything else like that. And so the area, to me, even though there's so much emphasis on it, it's just one data point for me. But it is a good one. And so again, for those screening cases, you know, if you see a case where you do this airway measurement and essentially anything less than 150 is going to have some trouble, it's a risk. So again, it's a prediction. It's not a diagnostic tool, but it's a risk prediction tool. And so 0 to 50 would be a strong risk prediction. And these were the researchers who came up with some of these numbers, or the papers where some of these numbers are come from. And then another paper also points out shape as well. And so anytime you get more of an elliptical indented shape like you see in this one, the risk goes up. So even if I didn't have the numbers on this one, just because it's indented, you can see the soft palate and the tongue just pushing back into it and partially collapsing it right there. I know that that's going to be potentially problematic right away. So some of it's numerical, and that's a good rule, and some of it is shape. Oh, and here's that shape correlation. Agawa did this paper, really good paper, where basically there's a smaller lateral dimension and smaller AP, and then obviously you notice more of an elliptical shape to it as well. And so most airways are kind of elliptical, but a lot of them will be a little bit more round. When you get these really flat, drawn out ones that are really indented, kidney bean shape, or really ribbon shape. The ribbon shape is kind of a name that's thrown out. And then you kind of, you know, you're suspect the red light kind of goes on a little bit more than the other ones. And where you'll find these airway assessment predictions now is even in these radiology reports. So here's a report right from Beam Readers, and they may or may not know that your patient has sleep apnea, or you may or may not know at the time, but they'll comment on it now. And so if they do this area measurement and they get that cross-section that falls in that, they just mention something like it indicates a risk factor for sleep disorder breathing. So they don't really diagnose it or pinpoint it, but it is mentioned as a risk factor. So that research is appearing in the clinical practice through these reports. So you can look for it yourself. And if you do send off for a radiology report, you might just see that mentioned. And so that's where that's coming from. If you ever saw that and they're like, hey, why did they say that was a risk factor? It's based off those papers. And so the airway, that minimum MCA, there's that minimal cross-sectional area. And because all these tools focus on that, I think it's valuable and people are looking at it, but we can't get too hung up on it. Because there's cases where it's going to be significant, and there's other cases where it's not going to be that significant. This case, it was interesting because his minimal cross-sectional area is actually pretty extensive. Even though the tightest one is about right here, he's actually constricted all the way down. And so getting an idea of that constriction was helpful for him, because he was one of those guys where it was like, man, I'm sick of CPAP. I'm done with this. I'm just ready to do the surgery. And, you know, anytime a patient says I'm ready to do the surgery, they're usually talking about the UPPP, which in this case is going to do nothing for this guy, because if they trimmed even all the way up here, the base of his tongue way down here is still constricted and still a problem. And so for this one, the MCA was significant in that it really ruled him out of that potential surgery, even though he didn't really want to go there. But, you know, frustration could have led him, and then helped us understand the morphology and view of his airway. And then also just teaching him, as you showed them this picture, and it was amazing. But this was a neat case where you could really take one scan and steer someone away from a surgery that's going to do more harm than good, most likely. Now here's a kind of the opposite case where the MCA was not significant. In this case, initially, when I first glanced at it, I didn't think the patient had a problem. And then I went through all the details and all the signs and symptoms. It was like, no, something's going on. And sure enough, came out as mild sleep apnea. But this one, there's no minimum cross-sectional area. It was all above 150. It's a huge airway. You know, everybody's, you know, saying hurrah. But there is a huge soft palate with a long uvula. And so the problem and even looking at the polysomnography, it was more of a snoring issue, which was kind of interesting to see. But again, this patient, even though it's not recommended, a UPBP might be a little bit actually helpful for this particular patient. But for the oral appliance, much easier to use an oral appliance, of course. And here's that note where you mentioned, Guy, about like that tongue posture. Here, there's a little bit of space. On this perhaps case, I also suspected mouth breathing. And this isn't so much of a really low or lazy tongue. I could usually see them even lower, but there was some mouth breathing in that case. So I found that sometimes that mouth breathing will manifest as kind of like a low tongue posture, even in the scan. So kind of a neat little side note on that one. Now, where we can be diagnostic is for things like this swollen adenoids. And so cone beam, you know, it can diagnose pathology. It can't diagnose sleep apnea, but it can diagnose pathology that's related. And so here's a case with very severe swollen adenoids that you can see. Again, it's right up here in the nasopharynx region. It should almost look like a corner back there, a sharp corner. Here's a normal one. And whenever it's swollen forward, that's going to pose a problem. Nasal breathing decreases. And then here's that low tongue posture again. Patients biting down, there's no reason for their tongue to be all the way back like that. So again, this patient's probably developed a low tongue posture, a mouth breathing habit, and open mouth habit. You can kind of just see that all in the scan. Here's another case where you can see the swollen adenoids appear, not as severe, but kind of bubbling forward. Again, that lower tongue posture. And then you can see the cross sections too. That's what that low tongue posture looks like. It's just not riding on the palate. It's just really low. It's lower than the occlusal plane there. The nasal passageways, other things are happening in that case. That's just showing that the swollen adenoids. And this was actually, was this a pedo? This was a teenager. And every now and then we'll find some adenoids even in an adult, 22-year-old or something like that. So for children, also look at the palatine, and actually adults too, but look at the palatine tonsils. This is actually a case of kissing tonsils where at one point they actually do touch. And if you look at shape, we're again with an elliptical shape, but this time it's changed direction. So if you see an anterior posterior airway like that, there's a big problem, something squeezing them from the sides. And in this case, it is those palatine tonsils. And we could look at that up close. This patient had both the swollen adenoids and the swollen tonsils, and just look how the airway was actually shaped due to that. Pretty substantial there.
Yeah, that's my slide, just to say that, you know, kind of back to the exposure, you know, I didn't have any reservations of taking this. My orthodontist wanted to take a scan and on this, my son, to see where his canines were. And we looked at all his airway, and I think everything looks fine as far as that goes. But there's just, you know, I felt we'd be remiss just to try to take the normal type imaging to see how we, you know, what position were they buccolingual and so forth. So that's why I dropped that in there. Plus, had to, you know, shamelessly put a picture of my son in the presentation, so you can move on.
Oh, it's a good catch.
Yeah.
Cool scan too. And there was a little note too, just to pause. Oh, actually, we'll let this play and then I'll talk about that note. Here's a 3D rendering of the that patient's airway with the tonsil swollen in from the side. So look at how much it's impacting that on the lateral there. And then on the top, it's going to look at the top, and there's where those adenoids are pushing down from the top. So really closing off the nasopharynx, making it nasal breathing hard, and then also closing it off down here and making it hard down there. So for children, as we know, sleep apnea can be caused by something like this. Same as in adults, but so always look out for snoring in children. It's especially dangerous because they're in that growth and development phase. Someone asked in the little chat just how significant have I found that MCA to be, and that was that minimal cross-sectional area. Again, because I look at so much other stuff, it's just one data point, but pretty much all of my patients, except for a few, have their MCA in that realm where it's under 150. And even the few that don't, the shape is usually off. So even if it's like 200, it will have kind of an elliptical or kind of a U shape, kind of bent in shape. And so I think that the MCA holds up, that rule of thumb holds up. Most of my patients in that range do have it. There will be patients where you find a small airway and they don't have sleep apnea, but I think that's pretty rare. Here was one of those implant cases where the patient took a scan for implants, and then we would look at the airway and we're like, oh my gosh, something's going on. So here's a patient literally awake, upright, and they're actually having an obstruction. The soft palate, the tongue is kind of pushed back into the soft palate, which pushes back further and closes off the airway. In this case, it was kind of a partial obstruction. We're going to look at that from a few different angles just to get an idea just more about what an obstruction looks like. I don't normally look for this kind of thing in like on purpose, but when it comes up, it's pretty neat to see. So you can see it from all three dimensions and how it really impacts the airway all around. And then there might be, yeah, here's another little video of it. And so where that black is, that's where it pinched off and closed. The airway is forced to come down here. So you can just imagine the turbulent flow. So this was one of those neat cases where we just told the patient, hey, look, we're scanning you for implants, but look what we found. This is, critical. You're basically obstructed while you're awake. Do you snore? And, you go down that path, and sure enough, there's another sleep patient. So always be on the lookout for that. I like to mention this next thing, visualizing response, but we don't do this as a standard practice. This is just kind of a cool thing, but it is pretty neat. What we can do is we can actually superimpose two different cone beams. So we can take a patient with and without and overlay them and see how they've changed. And I think this is actually a better slide for anatomy, understanding anatomy, than it is really the oral appliances. Because I don't do this to test my oral appliances, but we did it on, this was a research project. And you can see how it really impacts the airway in every dimension. And this is what we're finding, is that the lateral dimension does change a lot significantly. So just purely laterally, we got 10 millimeters of change with and without that mandibular advancement device. And then that airway, here's a case where this guy did have sleep apnea. Look at that, 390, so way above that MCA. So the MCA would have said no concern, but then the shape would have said concern, because you have that ribbon, that indentation, where the soft palate's really pushing on it. And then you can see just in 3D and in the sagittal view as well, anterior, posteriorly, we got some change, but circumferentially we do get change. So laterally, AP, everywhere, the airway gets pulled taut and expands in all dimensions. When we do an advancement. It's kind of just a neat anatomy slide for that. Let's see, go to the next slide. All right, so we also we're looking around the airway too. And so I kind of mentioned, look at the soft palate, I'm looking for swollen adenoids, I'm looking at, maybe swollen tonsils, looking at tongue posture, tongue size, the jaws. And then we also, the sinuses right there, the airways right there, and these things come up a lot where we'll see a blocked ostium and kind of some sinusitis, or a thin nasal passageway, or something going on, maybe a slight deviated septum. Something comes up, and every now and then it will be clinically significant. Here was a case where this patient has clear sinuses, clear nasal passageways, but they're very thin. He's always just reported constricted airflow, and if you hear him breathe through his nose, you can kind of hear it. He makes a little hiss sound, and this would be a really good case for one of those turbinate coblation, where you can really thicken these nasal passageways up just by doing the coblation, where it heats up this tissue. The tissue, basically, it's kind of like it heats it up, it kills, it shrinks, and then all of a sudden that airway passageway is much bigger. So this was a cool case again where cone beam helped kind of do recommend a surgical option alongside the oral appliance, and that comes up every now and then. Deviated septum is another pretty common one. Nasal passageways and sinuses, we'll see things that are not concerning as well. These mucosal retention cysts, I bring these up because they're really common, but you'll see these kind of like bubble-looking things. And those are typically transient. The only time that these become a problem is when they're right up here in the ostium area, and they're blocking the drainage point, which is the ostium. So the osteomatal complex connects the nasal passageways to the sinuses. And so unless you see one of those mucosals in that corner up there, they're usually not a problem. They're usually transient. What I worry about more is patients with just chronic sinusitis or maybe a deviated septum like this one guy. You want to talk about that one too?
Yeah, by the way, there's questions coming in. We're going to get to all of them here. We have just about 15 minutes left, so we're going to get to them in a little bit if we haven't already typed them in. But yeah, this person's got a pretty messed up nose, as you can see. And I can tell you why I know, because it's me. I had a little accident years ago, but you can really see things I found on patients that maybe don't realize they have problems with their nose. And Rich and I can, we haven't added a whole lot tonight, but we can certainly add that if you can't breathe through your nose, dental device therapy can dramatically be affected. And if we can get their nasal passages open by addressing allergies and addressing structural problems with the ENT, it can certainly make your dental sleep therapy infinitely more successful.
Yeah, and I think, you know, if someone comes in and they're congested and then you send them to an ENT and it's just like, hey, this patient's congested, figure it out, you know, it's helpful. But if you send them with a cone beam, and then now you're saying like, hey, look, they have a deviated septum, thin nasal passageways, and a clogged ostium. Now all of a sudden it's like, whoa, this, you know, thanks for the referral, because now it's a very clear, you know, medical referral. And so that communication is helpful. I just have a little bit here. I'm going to go through this fairly quick, but I use cone beam also to help me with, you know, cephalometrics and skeletal dental classifications. I'm always kind of curious about the growth and development and how they got to that point. And I usually see some sort of micronappia or retronapia in the maxilla is a problem a lot more than you think it would be. Class 2 is classic for sleep apnea, but we get a lot of patients with a micronaphic maxilla that caused the mandible to not grow, or vice versa. But we do get a lot of maxillary issues. So I do use the cone beam a lot, and I don't always do these really advanced cephalometric things. I just point them out because you can do them if you want. You can do 3D cephalometrics, you can do 2D cephalometrics with the cone beam, because you can make a regular ceph or a 3D ceph. You can do any of these. For me, I'll do a pretty simple one. I'll get some of these Steiner points, maybe a Witz appraisal. And for me, it really is, you know, is there a maxillary mandibular deficiency? And then I do other assessments as well. But these few ones I find very helpful, and they're pretty consistent for helping find patients' jaw classifications pretty quickly. That Steiner and then the Witz appraisal. And then if you do, you know, full analyses, obviously you can get into like a modified Grumman's or a Sassoon or whatever you happen to do for more of a complete thing. And so I like to look at this because here's a bunch of my cases, my patients. Class 2 is often associated, but not always. We'll get these patients with the maxilla problem. If you look to the far right, this patient has multiple things going on, but they're class 3. The maxilla is smaller than it should be. And the big tongue, huge soft palate. You can see how big that soft palate is just drooping back there. But just because they're not class 2 doesn't mean that they don't have it. You'll find it in class 2, class 1, and class 3. And then another point about class 1 is orthodontists always put patients in that, you know, dental class 1. It doesn't mean that skeletally they're different, and I find that a lot. And I'm kind of like that myself, where my teeth are perfect class 1, you know, occlusion, but the skeleton, the jaws are actually, if you do that A point B point assessment, the Steiner one, you'll find that like I'm a slight class 2 skeletally. So there is a difference between dental and skeletal classifications, and you can see that with cone beam. It helps figure that out. So keep an eye on all of that. This is just to mention it, but in orthodontics friendly, airway friendly ortho, what we're doing now is a lot of palatal expansion. So rather than extracting teeth and narrowing the arches and making the problem or making it worse, they're trying to do the opposite, where they're expanding the arch and building it up and making more tongue space. And if you're interested in any of this type of information, Dr. Juan Carlos Quintero and Dr. Sean Carlson, they're 2 orthodontists that have a lot of good material on this. So again, airway-friendly orthodontics, we're doing palatal expansion and uprighting mandibular molars just to get more tongue space and room in the oral cavity. And here's another just kind of a mention just to be complete about what's possible. We can do orthognathics as well. So if it did go towards that orthognathic surgery with the cone beam scan, you can now do the surgical scan. And I think that's what's so cool about cone beam is it's kind of whatever way the case goes, you can keep working with the data set that you already took to get information or to do a treatment plan or whatever it happens to be. A little bit of just a few quick notes on TMJ and cervical vertebrae, just because we're looking at it, it's there. This is the standard image in a cone beam software that we'll get. And it shows us in the center window, this is an axial slice, so patients kind of cut up and down in half. We can see their joints right here. And these slices are going semi-sagittal, and we get all of those individual slices of the joint there. And then the coronal one is this line that's kind of going right through it in a semi-coronal type of a fashion. And so we get a really clear picture of the whole TMJ structure. And that's what it looks like up close. And we'll move on to the next slide. So here's just one sample case. Every now and then, the patient will come in and then you just see something like this. And this is what you should look out for. This is like the one pearl for TMJ. It's like a quick and dirty pearl. Look for just irregular borders or look for any break in that occlusal pattern. If you don't see a nice white rim like that in the coronal and in the sagittal, something's going on. So in this case, there's sclerotic and it's starting to resorb. So there's actually some active degeneration happening there. So again, I noticed, hey, there's not a clear cortical boundary. Sent it over to beam readers, and sure enough, it was severe and active DJD. And you had a point you wanted to make here too. Okay?
Yeah, I think it's going to answer the question. One of the questions that came in is how often do we send these to a radiologist on these bigger images? I personally send all of them. They charge us about $75, and I want to share the liability a little bit. And this is an example of I just copied and pasted what came out of one of the reports. And, to me, this kind of helps protect me. I've mentioned to the patient, you have some non-active degenerative joint disease. You may have changes in your occlusion due to this. And, we already have informed consent, but I really feel, we talk about a lot of reasons why we need to have this, but having a good baseline and knowing what the structures are to start with, especially the joint and the nose. And so I have them all read on the because we're taking primarily all big images. So that's me. That was one of the questions. Do you have them read, or what do you do?
Yeah, I do, and I like them read for a number of reasons. One is it's for me. I actually really enjoy the report. It's
right.
Very nerdy sounding, but I learned so much from every report. So
Absolutely.
each report, it's kind of like a mini little CE course, and I literally think of it like that. And then I do think getting the report read, it does share the load and the responsibility. It gets a second set of eyes. And my patients respond well to it because they see me as if I have like a team around me. So it's like, yeah, my radiologist said this, my sleep physician said this. And so I keep having these big medical kind of people behind me. And so it builds me up. And then if I do have to talk to an ENT or a surgeon or a physician or whoever it might be, having a radiology report, it really pinpoints what I want to say in the anatomy, about the anatomy. Because to them, it's like, hey, nice image, that cone beam's really fancy, but what does the report say? So if you do want to collaborate with other medical professionals, they're just kind of like, hey, send me the report. And so it is kind of the official work product for them is just a radiology report. And so for me, it serves that purpose as well. And then also I'll follow up on your point too about the TMJ, specifically the TMJ, the cone beam offers just a wonderful snapshot. So a baseline record, this is how patient came in, this is exactly where their joint look, from every different angle you can see it. And this slide here is a little scary one, bunch of images with pretty severe pathology. Big things like that you would notice. Obviously, the smaller ones, hopefully you would notice too, and the radiologist would pick it up as well. But I just put this out there to talk about that radiology report. Again, this kind of actually summarizes what I just said, but it's a great screening tool. So I do send it. It's a service to the patient. they have to be read anyways, and so somebody has to do it. We can say that we did it, we went through the whole scan and scrolled through every slice and read it, or we can have a radiologist sign off on that. And then, in dentistry, technically, if we do the readings, we're supposed to be able to do it according to how good a radiologist can do it, because that's their specialty, and we're supposed to be able to act to the same level of a specialist. And I can't do that for radiology, so I just send them all out, and I'm learning with each case as I go. They're huge sciences, and it's just amazing. Every case that comes up, there's some new term I have to look up. And then I mentioned this, partial read consent forms are not valid. Most people won't know what this means, but what that means is there was this idea where you could tell the patient, well, hey, I'm only going to look at the oral part of this scan, and the rest we're not going to read. That you'll see that in older kind of patient forms where it's trying to get them to accept, or it's trying to kind of limit your responsibility, but that doesn't work. That was kind of in vogue for a while, where they were saying, hey, the scan gets more than just the dental area, but we're just going to look at the dental area. That doesn't really work. So I wouldn't recommend that at all. If we take an image, we're responsible for everything in it. Every image is the same, even the pano. So in summary, we went through a lot and kind of mentioned a lot of points, and this was really probably more of a teaser, because each one of those elements we could have, gone down a pathway and talked about all sorts of different cases and things, but this is just a good overview of what cone beam can do for us, how we can work with it in dental sleep medicine patients, what limitations there are, what advantages. And so limitations, again, it's not diagnostic, it doesn't substitute the sleep test, but it can be a great assessment tool and screening tool. And so if you see something in the cone beam that makes you think airway or a problem or sinus or this or that, go down that path and you have the image to back you up. It is a diagnostic tool for pathology. And so that's where it's not diagnostic for sleep disordered breathing, but it is diagnostic for the pathology that's in our domain. And so it is a good diagnostic tool. We get a baseline, so we talked about that, legal protective measures, having a baseline of their anatomy, whether it's the condyle or even the teeth, it doesn't matter. We have a complete baseline of everything. And then I think it is a great screening tool, especially when you took the cone beam for something else. Always just look at the airway. If you're one of those GPs you're doing implants, you're doing airway, you're doing everything. Pretty much whatever you scan for, just take a quick peek at the airway, look at the soft palate, look at the nasal cavity, get an idea of the shape of the airway. And pretty quickly, and even just under a minute, you can do a pretty substantial assessment of the nasal cavity and the airway just by scrolling through a few times. And then this is big, and this might even be the biggest. It's just such a great communication tool. And anytime I need to talk to a medical doctor or physician or an ENT or even another dentist, having that behind me, the radiology report, it just puts such an official seal on it. It's as if I'm coming almost with like a team of like a whole team, and that's how it feels when I bring the report, because it's like, oh, there's the official report. People respond to that, dentists do, and especially in the medical community. Again, in the medical community, if you give an ENT a picture of a cone beam, it'll help them, but they'll be like, hey, where's the report? So they just kind of expect the report. And I think I have that. Yeah, the last consideration is that report. And so
Doug,
again,
I'll add one to the advantages. I mean, I think those are great advantages, all of them fantastic. But you know what it really does for a dental sleep patient? It adds value to their dental sleep care. I mean, one of the things we hear a lot is, oh, how much is it for this piece of acrylic? And we've got to explain the whole process and build value. The amount that they pay for the cone beam and the read, they see value in the radiologist being involved, just like you mentioned. I believe it adds more value than what it costs them. They see the image, it wows them. They feel like you're extremely comprehensive, and it really, from the patient's point of view, it builds a ton of value. It really does.
It really does, and I think that point is such a good point. And just to jump on it again, that value is they initially might come to you for an appliance,
Right.
But all of a sudden they're like, man, I'm doing a scan, I'm getting this intraoral assessment, I'm getting all these questions, and it's like, wow, they're doing more detailed report on me than my sleep physician.
Yeah.
I mean, that might be how they feel.
Right.
And then you might even find something like that deviated septum. I discover a lot of things that patients don't know about deviated septums, polyps and random stuff. And then all of a sudden now you're kind of the hero in a way that found something. Because for anybody, even if it's a small piece of your medical mystery puzzle, if someone finds a piece of your puzzle, like, you're going to remember that forever. It was like, oh, my dentist found that,
Right.
So cone beam can potentially do that. And the patients see the value. And I use it for patient education as well.
Right.
I'll open up that cross section and point out their soft palate and, and really utilize it. So thank you everybody for letting me speak to you about all that.
Yeah, well, thanks for being on. We're going to get to these, make sure we've gotten through all these questions here in just a second. I want to thank you before I forget that was fantastic. And if anybody wants more information, they can contact you at clinicallycorrect.com. Is that the correct address? Clinicallycorrect.com?
Yeah.
All right. Well, write that down, clinicallycorrect.com, if you want. You have some DVDs and then you offer hands-on training as well.
Exactly. Yeah. So if anybody needs help with cone beam education, you can reach out to me directly. Just go to my website, Clinically Correct. Take it from there.
Fantastic. We'll get through the rest of these questions, and we just want to mention again, because some of you came on a little late, next webinar will be July 11th. Rich and I will get to do a lot more talking on this one because it's more in our wheelhouse of expertise. We're going to go through dental sleep medicine and really what you need to do to get the team on board. And you can read the bullet points. One of the key things here we think is identifying a sleep ambassador checklist, and really, how do you jumpstart your practice? And what we know is dentists are busy, and if we get the team involved, we're going to get you down the road of dental sleep success. Also, I mentioned earlier today, and again, we're going to get to the questions, but I want to make sure we have this up here as we're answering the questions. There's no organization around that does more to help dentists succeed in dental sleep. And if you've got questions about insurance, to which device to use, to TMD side effects, success rates, just type in consultation or free consult into the chat box, and one of our dental sleep medicine experts will set up a time to sit with you and address your concerns, tell you how we can help you with that. Also, I didn't mention this earlier, but Dental Sleep Insider magazine that we publish every other month has just fantastic articles, videos. It's free. So I'll say that again, free. Go to dentalsleepinsider.com just to sign up for that, and I'll flip back to these again in a minute. I thought we had our courses up there again, but apparently I think that's the last slide. So we didn't have the courses there again, but we have courses all throughout the country. And if you think you might want to come to one of our courses, just type in course and you'll get a $200 discount off a 2-day course. And we are offering $100 off of a 1-day course just by typing course in, because we normally only do 50, but we were just feeling generous today. So I got through that. Let's see, there's questions that we didn't get to here. Have you answered those, Doug?
Yeah, let me look through here. Okay, so one question, any luck on insurance coverage for cone beam? On the medical side, you can bill medical insurance for the cone beam scan. The challenge is that they'll often ask for some sort of reason or explanation, and you might even have to do a peer-to-peer. So the insurance company literally might have one of their doctors call you to ask you why. And then you just have to say something like, oh, well, the patient has chronic nasal congestion and we don't know why, and we need to figure out why it's related to the sleep apnea or how it's related. And so it can create more work. So is it possible? It is possible. Do you want to do it? Maybe, if you don't mind doing that quick peer-to-peer and maybe filling out another form. If you have an insurance billing service like DS3 has, they can just do that for you. So that helps out a lot. You still might have to jump in and answer a question or two, but there is a procedure for that, procedure code for that, and it is something that's billable. And I've gotten some success with it. Sometimes I've gotten them denied, and I've done a few peer-to-peers, and I've gotten a handful approved as well. So it's similar to excuse me, it's similar to the oral appliance. I actually get way better results with the appliance than with cone beam, but we do get cone beam approved as well.
I think the key there is that you have to show there's a medical necessity for the image, because we do get coverage a fair amount of times, and it really depends on the insurance coverage as well. And as you mentioned, we do billing for hundreds of offices, and I don't think we do your billing. I know you use DS3 though for management of your patients and so forth. Yeah. So you can attest to that. But as far as the cost of those reads from the radiologist, we just include that in their fee. And they realize that when we talk about building value, look, we're going to do this image. Here's why we're taking it. Here's all the important information we're going to get and why. And we're going to have one of our team radiologists, and this fee covers us paying them for that. So that's the way I handle it. How about you, Doug? Same thing?
Yeah, that's a good way to do it. A lot of the times I'll do it just like that. If on the times where I got the cone beam covered, sometimes the cone beam procedure, it's cone beam with interpretation, so the insurance might cover it. And then another thing to do just on this whole kind of billing question is I use the cone beam as a advanced consult fee. And I don't always do that, but I tell a patient, like, hey, look, you're coming in for regular consult, but I think we should turn this into an advanced consult and get some imaging. And then they like the sound of that. They buy it, they pay. I just have them pay cash right then and there, a smaller fee than normal. But it gets them on the hook a little bit. And now they're kind of like, hey, I just came to the office, I did a consult, I took a scan, a radiologist is going to read it. They're already kind of like, halfway signed up essentially. So sometimes I do a number of things, but it could be one of those advanced consults to kind of, help get them going. If they're really tight, I just wrap it into the cost of the oral appliance. If they got really good insurance, I might actually try to bill it. So I kind of play it by ear, but I've been leaning towards that kind of consult, the advanced consult fee, because I think it helps get people serious and it gets them motivated and it gets them started. Let's see.
There's some questions about the shields.
Yeah, there's a question about shields. I don't have any idea what that's about. What's that about?
Are shields recommended for skull or thyroid? We use a lead apron. We don't use the thyroid shield because it'll get in the way, but I'll let the expert go ahead and answer that for us, Doug.
Yeah, it's the same thing. We use the lead apron, and it just drapes over the shoulder and all that. We don't really get into the neck or anything with the thyroid collar because it would get in the way. But standard protocol of any other dental X-ray.
Question here for me. So at which point do I talk about the CBCT? I talk about it at the consultation. We spend time talking about what we call dental sleep therapy. That's what I like to call treating patients with mandibular advancement devices. And we describe the whole procedure and why each step's necessary. And we describe why a 3D image of the anatomy involved in this treatment is important as a diagnostic, maybe to see things we didn't think were going to be there as far as the nose and TMJ, at least at the very least to have a baseline for these structures. And so we mention it in the fee. And yeah, I do have a separate fee. The vast majority of patients in my Braden office get a CBCT. Most of them in Sarasota do, but we have a Tampa office that's an hour away. We only have one cone beam. So, they have to come to the other office to do it. So that's why we've separated it out, because we just know that some of them won't come that far. So do you have anything to add on that, Doug?
Yeah, well, mine's pretty similar to that. I think the consult's the time to mention it, and then to also mention that holistic, therapy that you're doing. It's not just an oral appliance. We're doing a therapy that is comprehensive, and we need to look at your whole anatomy. And that's kind of some of the phrase I use right there. And so I'll do kind of a regular consult, and then I mentioned to them I want to see your anatomy, and actually I think we should turn this into an advanced consult right now and take that image. And then they feel really good because it's like, oh, we're taking another step already. We're already doing a consult. Now we're going to the next step already. And so it kind of gets them going. People ask about fees and stuff. You could do whatever you want. Again, you can try to charge them right there, which I try to do just to get them kind of committed and I found that that helps. Or you can wrap it into the cost, see what works, see what helps. But other than that, again, that consult, you're really stressing the comprehensive nature of what you do. And even if you don't use cone beam, you still mention those same points. We're concerned about all of this anatomy, and we're going to be asking you questions and doing assessments much more than just, an appliance. You're not here for an appliance, you're here for a therapy modality, and that's what we're offering.
What's the minimal field of view that you would suggest for sleep and airway? That's one of the questions.
Yeah, no, you can do a medium or the large. The medium fields generally get the whole oral cavity back to the airway, and then sometimes they go into part of the sinuses, and they sometimes get the TMJ completely, sometimes they don't. So the medium field is useful because it does get most of the airway, and a lot of times can get the TMJ. If you happen to have a medium field, taking a lower field of view and then an upper one to get the upper structures like the TMJ, it's not a bad idea. Again, these the doses on the medium fields are so low that you could take an upper and a lower if you needed to. If you're thinking about machines and you want to look at the condyles, you want to look at the full sinuses, everything, then you'd probably be looking more at a large one. But again, even people with the mediums can still be looking at the airway. Small field of views are generally so small that they're more of the endodontic region. You're just looking at a few teeth, so they don't give you the depth that you need.
When I was looking at this machine, I think I mentioned already that the exposure was important, but then also I wanted to be able to see the airway, the teeth, because I use it for the super pano feature as well, so I can assess if there's any notable things going on with the teeth, the nasal passages, and the TMJ. I mean, if I'm going to treat the patient, ideally I want all that. Now, some machines you have to take two scans to get that and kind of piece them together. Some of them get it all into one image. So for me, I'm doing tons of airway. I want to be able to get those structures in one image that I could look at. I felt that it was important for me. I'm not saying you can't do it with the smaller fields, but if you're looking to buy a unit, consider what do you want to look at? The joint, the airway, the teeth, and the nasal passages. And so we try to get one of those. That's why I got the OP300 that I did, because of the exposure and that it captured all that. And I didn't really want maybe some of the other information that some of the even bigger ones than I purchased got. So
yeah, the OP300. Yeah, no, that's a good point. That machine's a good one. The OP300 has the that whole structure that you're saying. It's like it's like right from the top of the nose, like nasal on down. So you can do most of the orthodontic assessments too. But you're, like you said, you're not on the line for the whole head and neck with everything, but you still have a good picture of all the areas that you need. And
who do you use? Your radiologist is the next one on here. If you're scanning.
Yeah, I'm biased because I did work with beam readers when I was doing the implant planning, but working with them, I saw how good they were, and so I hands down recommend beam readers. I use beam readers. There's other reporting services out there, so you could use pretty much whoever, but I like beam readers. They're very consistent. They deliver consistently good and organized reports. It's always organized with the same layout, the same template. So they're really they've been really solid. Just upload, download, super easy.
I think we got, again, if anybody is interested in the course, I see quite a few typed in course. You can decide which one you want to go to, but we'll offer that 100 off the 1 day and 200 off the 2 day. And if anybody wants any further consultation about dental sleep, just type in consult, free consult, and one of our team will just meet with you to see what your challenges are. Again, if you need to get a hold of Dr. Chenin and wanting to know more about questions he might answer, can they get in touch with you there as well, clinicallycorrect.com? If they just visit that, then you'll they can, right?
Yeah, there's a little like contact us page in there.
Okay. So just clinicallycorrect.com to
Yep.
talk to Dr. Chenin directly or answer any of those questions.
Hey, Doug, I want to say thank you. I learned quite a bit here. You know, I'm still having a little bit of a hard time because I haven't seen that many images. You know, what's front to back, top to bottom, left to right. You know, as I do that, I'm having trouble kind of in my mind. But I would imagine that you know, after a while, you see a tooth upside down and backwards in a mirror. You know, when you start drilling on them and that kind of thing. So I would imagine, I would hope that gets easier.
Yeah, it does. And I think that's another good point for the radiology report, is the more that you kind of force yourself to look at an image with a description like a report, you know, you really do get a good handhold on what things are. And they point out stuff too. So in their report, they'll usually capture about 3 or 4 pictures. And so they write it up and then they're pointing out a few structures. And so slowly by surely, after a handful of reports you read through, it just starts to pop out. And then
I kind of do it like a little test. It's kind of, so I try to read through it myself and make notes and see what I see.
Yeah.
And it's kind of fun. It's
Yeah.
like, I mean, it really is. I mean, I'm not just saying that. It's truly kind of enjoyable. You look through it and you try to see what you come up with. And then I look at the report and go, oh, I missed that. And then I go back and I see what I missed. And then, you know, I learned something, just like you said, you learn from it. So,
Yeah.
it's
Yep.
like a little course, like you mentioned it. I kind of do it
It
that way
is.
though. I do it without it first. And then I go back and, you know, first few I looked at, I didn't see anything. And then when they mentioned that, I go and see what they saw. And it's really, it's fun. I think it's kind of.
Yeah, no, it can be fun, and it can also be neat too, that same kind of guess and play work if you get a scan before they take a sleep test. So I had one patient who was referred to me. It was a pediatric patient. They were just showing me the cone beam, and they said, "Hey, what do you think? Do you think this patient has an airway problem?" And it was a whole number of things going on, but, you know, congested nose, swollen adenoids, low tongue. And so I kind of just said, you know, I think this patient's a chronic mouth breather. They got chronic nasal congestion. I think they're snoring. I think this, that. And then they did the sleep test and they sent it to me, and it was so cool. It was so validating. It was just like everything I said was listed out. It was like, yeah, patient was mouth breathing the whole night, snoring the whole night, nasal congestion. It was really neat to see. So yeah, use it as a tool to kind of guess and test and predict, and then when you get the reports back, you can look back at it and see how good you guessed.
Yeah, I want to say one more thing, Doug. I figured out why Guy likes this cone beam stuff. You know, his mom and dad were both psychologists, and I have to say those images kind of look like ink blot tests, you know, I took back in the day. So
yeah.
Yeah, I'm not gonna tell you what they meant to me, but no. Well, you know, I do. I like, maybe it's because I like computers and so forth. But I can tell you, it was much, back to your concern or question, maybe, Rich. It was much easier to learn and understand these images than I thought it would be. When the first time I looked at them, they were extremely intimidating. And it really, the learning curve was less than I had envisioned. I don't know if that's true for most people, but for me, I maybe had envisioned a lot worse learning curve.
That's kind of where I am right now. They are a little bit intimidating when I look at them, because I don't know all of that, and that, you know, as you point them out, I go, oh, okay, that makes sense. So that's good to know that it does get easier.
I lost
Yes.
Rich.
Yeah, I would say just jump in and look at them in the software, look at the reports, and don't be shy with it. Just jump in. It can be intimidating, but it all starts with one step.
Right.
Awesome. Well, thank you so much, Dr. Chenin. And if you guys want to learn more, you can check him out on his website and his DVD and that kind of learning. And, you know, at DS3, we're always here to help every dentist in the country get better at doing dental sleep medicine and implementing it in their practice. So Are we about done, Guy?
Yes, sir. I just thought I'd throw that last one up there. The next one, Rich and I get to talk a lot more, so make sure you sign up for that. And we appreciate you taking the time, Doug. We look forward to seeing you hopefully sooner, but if not, at our symposium in February in beautiful Clearwater. The weather will be nice. We've already put our order in, so I look forward to seeing you there. And thanks for your time. I truly enjoyed it and learned something myself. And so
thank you.
thank everybody for, we had quite a big attendance, and thanks everybody for taking your evenings. We hope to always deliver something that is worth taking the time out of your busy lives and your family's lives, your work life, whatever you sacrifice to be with us. So we'll close it down, and we'll talk to everybody hopefully on July 11th. Thanks again, Doug. We really truly
Thank
appreciate
you.
it. All right.
Thank you. Have a good night, everyone.
Good night.